Hi, my name is Pamela Nye. I'm the clinical nurse specialist for neuroscience and the stroke coordinator here at UCLA Santa Monica. Today we're going to talk about neuroassessment, and this is going to be a four-part series. We're going to start with the very simplest neuroassessment, which is called the Neuro check. First off, every neurological evaluation begins upon walking into the room, because you can see the patient, you can hear the patient talk, you can get a sense of what he's thinking and how his brain is functioning. Generally speaking, you can tell if there's something wrong with someone's brain just by talking to them. Excuse me. The first thing you're going to want to do is begin with a pupil check. Now, pupils, under normal circumstances, can be of varied sizes, but usually somewhere between 3 and 4 millimeters in diameter. And a pupil check is actually a check of cranial nerve 3, which is in the brainstem, and it allows the pupil to react to light. Under normal circumstances, pupils are round, and they do react to light by constricting. Now, when you try to check someone's pupils, try not to go directly into their eye like this, because that can be very painful, as it can be painful to the meninges. But rather go in from the side, and you'll still get the same effect. The pupil will still constrict. Another thing that's interesting about the brain and about the pupil is that when you shine a light into one eye, you will get an equal reaction in the opposite eye. It's called a consensual reaction. So once you've done a pupil check, the next thing you're going to want to do then is to notice whether the pupils are equal or not. Because generally speaking, if one eye, let's say this eye, has a larger pupil, then there's a problem on this side of the brain. And if the patient had pupils that were equal prior to your coming to the patient's bedside, and they're now unequal, this is something you'd want to report right away to the physician. Another thing that you're going to want to take a look at with the patient is his ability to move. And when we do that, we usually do all four extremities separately, beginning with any extremity that you know is strong and normal. So what you do is, I don't want you to get confused by the NIH stroke scale, because the motor evaluation is different than the NIH stroke scale, which is a 0 to 4 evaluation. We do a motor evaluation that is 0 to 5. And it begins at the 3 mark. In other words, 3 over 5 means that the patient is able to move their arm up against gravity. Now, you want to know how strong that arm is, so ask them to move it up against gravity, and then you push down on it and see if you can overcome them. And if you can overcome them, but they were able to give you any amount of strength whatsoever, then they are a 4 over 5. Now, in order to be a 5 out of 5, you ask the patient to push their arm up, you push down, and you're pushing down hard while telling them to push hard against you and try to overcome your pressure. Now, a 0 is no movement whatsoever when you've asked the patient to raise their arm. A 1 is a flicker of movement. In other words, you can see the muscles tense, but the arm doesn't come up at all. And a 2 might be the ability to bring the arm up slightly, but not have it come up to a midline position like 3, which would be 3 over 5. The other thing that we're going to want to take a look at is the patient's ability to feel, or their sensation. And what I usually do is I'll ask the patient to close their eyes, and I'll say, I'm going to touch your face, and I want you to tell me if you can feel it or not. Do you feel this? Yes. Do you feel that? Yes, I do. Do they feel the same? Yes, they feel the same. Okay, again, touching. I feel that, and I feel that. And yes, they feel the same. And you would do the same thing for the forearms, both left and right, and the lower extremities, not the feet, but the lower leg between the knee and the ankle on both legs. And then you would determine whether the patient had full sensation on all four extremities, or whether sometimes you'll hear the patient say, do you feel this? And they'll say yes. You say, do you feel this? And they'll say, are you touching? Yes. I don't feel anything. That would be considered frank numbness. Now, a difference in sensation might be someone who says they feel this, I feel it, but it's different. And they'll say, is it stronger here? You'll say, is it stronger here? And they'll say, yes, it's not as strong on this side. And then you will test all 4 extremities as well. Now, the other thing that you're going to want to do is you're going to want to take a look at the patient's awake state. Normally, patients are awake and responsive. Even patients who are awakening from anesthesia should be able to awaken to your voice. So when you're talking in a normal tone of voice, and if you're having trouble keeping the patient awake and attending to you, raise your voice and see if raising the voice helps make the patient more aware that you're there. If raising your voice doesn't do it, you may have to take a hold of the patient and shake their shoulder and call their name. And if that's what is allowing them to stay awake and attend to you, then they have taken a step down in the awake state, and that needs to be noticed and reported. Another thing that you might find is shouting at the patient, shaking the patient makes no difference. The next thing you need to do is take your knuckles into their breastbone and rub. It's called a sternal rub, and that's the application of painful stimuli. And if that's the only way that you can keep that patient awake, they are definitely neurologically deteriorating, and that needs to be reported immediately to the physician. The last thing we're going to want to pay attention to is the patient's cognition. And my favorite cognitive question is, why are you here? That presupposes that the patient, A, has a little bit of recent memory intact. In other words, they can remember how they got here. And it also is a good orientation question, where in fact am I? They should be able to tell you something along the lines of, well, I know I'm in the hospital right now, and last night I think I passed out and my wife got all upset and called 911, and that's how I got here. So that is the simplest neuro evaluation of all, called the neuro check, and it's something that you can do when you need a little bit of information in a little bit of time. It is in no way a comprehensive neurological examination, but we'll be talking about that in a few minutes.